Good afternoon. It is still April 16th, Wednesday, and we're continuing on sections 4, 5, and 6, which pertain to hospitals, hospital budget review. And we have in some hospitals with us today, not the actual physical hospital, but trying to get my drift. And we're joined first by Joe Wooden or Joseph, do you go by?
Joe, unless I'm in trouble.
Joe from Copley. So you want to come up and join us?
Thanks.
You're good.
Okay.
Yeah. It's not nice.
Start over here.
You're good.
Okay, great.
Side work, finish, get this out.
Looks good. I do. Thanks, everybody. My name is Joe Wooden. Live in Elmore. Sort of Morrisville and Stowe. The CEO of Copley Hospital. And it's a hospital. We don't have primary care. A lot of hospitals do. Many of them I've worked for. So it's a little bit unique. We're more like an old-fashioned hospital, just particular hospital services. We do have some independent living. We have a couple of other services, but that's for the most part what we do. And I'll share some of that with you. Any other relevant experience? I love that. I'm coming off the sheet here. I came up to Vermont. I'm new to the state. I've only been here 42 years. Started as an industrial engineer working for Belden Wire and Cable in Essex Junction. So my background is systems engineering for quality efficiency. I work for MCHV. Anybody know what that is?
Yeah.
UVM right now. Then I worked for Central Vermont Medical Center. Then I was the CEO down at Gifford for about 16 years. Went to Martha's Vineyard. Went to Homer, Alaska. And
That's your place.
And I'm back in Vermont, been here about 5.5, going on 6 years at Copley. So I've had sort of an interesting experience. I've seen a lot. I know Vermont very well. And I'm happy here to give some testimony. I'm going to enjoy it. I don't know about some others. Might not appreciate it. So I thank you for all the work that you do. It's very difficult. You guys have a lot of demands and people that appear before you with needs and interests, and it's hard to sort through that to figure out how to make a decision. I'd just like to express, I appreciate folks in politics because you have to make tough decisions, and we should always thank you for that, as opposed to trying to pick on you all the time to do everything that we want, and then it just seems horrible. It would make me quit my job if I was you. Let me walk through a couple of issues. That doesn't work. I'm going to have to use my finger, which is not very good. Just a picture of Copley, just showing that because we really enjoy what we do. We're an independent hospital, which is great. Been there for 93 years. And that's kind of just an overview of some of our services, what the organization does. We're small. We're one of the 8 critical access hospitals. So there's basically 3 types of hospitals in the state. Critical access hospitals, there's 8, and you get PPS hospitals based upon their payment system. Critical access hospital gets paid here, PPS hospitals, and then you get UVM Medical Center, which is part of a PPS hospital, also academic. So that's that. Let me see. Those are some of the services we provide. We're very busy. It's great. We don't have a problem with being busy for the most part. So our problem is just sort of putting up the demand and the interest of patients coming to us, which is great. The most important issues in our strategic plan, which continue in 2025, we call this a gap year, much like a wayward student not going to college. We're still in 2024. Finances are number one. It's a big concern, our sustainability. Our finances have always been sort of very fragile. Quality, of course, is important, and we'll never leave that list. Workforce and culture, and keeping care local with as much as we can do. We certainly all learned a lot through the pandemic about if you couldn't get care locally, you get sent to a tertiary care center. And during the pandemic, we realized, oh my gosh, they won't accept. You can't even get a spot in the, whether it's Dartmouth or UVM or even all the way into Boston. So those were interesting times. I bring this up, my favorite report. Thank you. Just giving everybody's listening. It isn't a bad report. I like this report. You know, my previous list of services, this was Oliver Wyman, from Act 167, sort of asking everybody, let's look at all the hospitals, the services, and let's see if there's an opportunity for improvement or maybe stuff we shouldn't be doing. I know some people take offense to the report. Directionally, I think the report is fine. You know what I mean? You can pick on small issues. So I appreciate you folks starting that, everybody in the State House sort of starting that discussion. It wasn't too soon. It took a couple of years. So here we are now with hospital and healthcare being continuing a problem. Here's a chart of our history. We're really good at losing money. It's been very difficult. So the budget is the purple line. We pretty much lost money for 8 years, although during the COVID years, we did get federal relief. So anytime somebody shows you budget information as a hospital, they should delineate the COVID money. So this COVID money allowed us to have a 5% operating margin, which is crazy. But if we didn't have it, it'd be negative 1.2. So those nuances with data are really important. That wasn't a small amount of money that the feds gave all the hospitals and states, which we really appreciated. Last year was the first time we made some money, 1.4%. Operating margins are important because you've got to invest back into the program, facilities, infrastructure. A healthy operating margin across the board for a hospital should be between 2 and 3%. That's what your bondholders, people in Wall Street would say, listen, a healthy operating margin should be about 2 to 3%. If it's well beyond that, you should be lowering your prices. I know I get in trouble talking this way. And if it's well below that or it's negative, you should really think about what you're doing and maybe cut back because you can't operate with a negative operating margin. So we've been doing that for a while. COVID sort of threw us into a tizzy in 2020.
Leslie, I'm sorry.
We operate through the church, so.
Okay.
Can you talk about what happened in 24 and why you had a positive margin that year?
We worked particularly hard. We got an increase from the state with what we asked for. Volumes were up. So I don't have it. There's no particularly, every year previously, we always thought we'd at least break even or make an operating margin. We just never sort of made it.
So no magic that you knew you did X, so
No.
therefore you got Y.
No,
Mhm.
That's a good question, though. I should have a better answer. I don't. Thank you.
Sorry, can you clarify the numbers on the bottom? These are
Budget and
that's
actual.
your,
So this is the budgeted number, which is in purple, and then the blue is the actual number.
okay.
So we budgeted 76,000, we lost 2.2 million. I think you need to always, I'm a big fan. I learned this in manufacturing and industrial engineering, run charts over time. One data point you see over a period of time, how well things are going. So we're feeling a little bit better, but it's not without working extraordinarily hard and getting through COVID, which was tough.
Not Leslie, Lori.
And obviously it's early, but how is your first quarter looking?
Looks pretty good. Small hospitals, we're so small. How small are you? We're so small that at times 1 or 2 providers being out, or if somebody had a medical condition. So it's kind of interesting. We reconcile things through a Medicare cost report. The cost report looks at information almost a couple years old to see as to, it's a complicated construct, but it's almost like if you owe taxes. So we just finished paying all our taxes. And if you owe the government, they say, well, you owe us a check for 2,000 or we owe you 2,000. So the cost report is like that, but it's delayed. And our estimate on what we owe the government was wrong this year by couple million. So it's been off a lot. So this year we're trying to figure that out.
Okay.
Because that's a huge number that you have to manage. If you get your cost report estimate wrong. Anybody make that mistake in their taxes? Raise your hands. I raised my hand. You guys are all really smart.
Just have expensive accountants.
Yeah. Here's something interesting, and I'm going to sort of tie this in. So I've been tracking the details of Vermont's system since 1999 when I took my first CEO job in Vermont. In terms of what did each hospital ask for, what did they get approved, when were they clipped because they asked for too much. So any red circle means that they got reduced. That's all. You can't read all this, but any red circle means that they got reduced. And then a black circle means that your reduced rate increase to an already submitted negative increase. And most of those are with Copley. I'll share that with you. So Copley's problem is for many years, we didn't ask for enough money. So, for many years, we're the longest run of any hospital where we didn't ask for enough money. And that became a problem. So that's what I've discerned, having worked in a lot of hospitals. Copley, why didn't you ask for enough money? And there's some stories maybe about a CON or a surgical CON. It's all history. So that's Copley's problem. Of course, Owen Foster's not in the room, so I can make a joke.
He's on the.
Oh, Owen's he's on the line?
I'm joking.
Can't even think a word that rhymes with Owen Foster. But this is the state's problem, I think, in the sense that Copley in these years from 2015 on, right? So we asked for 0 and we got 0. Very good. Wow, that's excellent. We asked for -3 and we were given -4. That's really unusual. We asked for 0, we got -3.7. Wow. We asked for 0 again, got -3.4. I just feel like there's some punishment going on here. There's something, I don't know that I wasn't here. I saw this from afar, but this is sort of the data that Copley really didn't even not only keep up with rate requests, but even if you asked for 0 or negative, you got less. So the state did that. I wish they were looking at data over time to say, wow, this doesn't make any sense. And nobody's really looked at the rates. Now, all of this is building up to the discussion of what are our charges? What are our rates? What are our costs, so to speak? And, what I've been presenting this for 4 years in a variety of forms. So this took me nothing to put together. The stuff's all out there. So that's a little bit of a problem. Like if the state sees a hospital making too much of an operating margin, there should be a question about, wow, do you need that much money? Should you reduce your rates? Of course, they would do that in the bond world. Or if you're not making enough, what are you doing to kind of get better? This is a case where if somebody looked at it, they're like, how did you earn such, what I mean? I don't know that, but I've been trying to fix that since I got here. So when it comes to reference-based pricing, which is a really funny series of 3 words, which I somewhat understand and not. We always package things so the public doesn't understand it. I still talk about what are the charges when I get a bill? What are the fees that you charge? So back in 21, I started this. This was on the top, it's inpatient room and bed rate. That's an old-fashioned term, but it's still important. Emergency room levels of care. In every hospital, the physician charges are just one of 5 categories. So it doesn't matter if it's UVM or anybody else. ER visits are only those 5. Diagnostic imaging, these are just a number of them, again, from 2021, 22. You know where you get this data from? This is actually out there on the website. So hospitals in America have to publish that. The government started that. Vermont was a little bit on the cutting edge with Act 53, doing a great job saying, we really want hospitals to do this even more. So Vermont was even more so on the cutting edge. The problem with the language and the hospitals is we haven't been very helpful. I don't represent the Hospital Association. Is that okay? All right.
You remember.
It's okay. I pay a lot. If you kick me off, I'll save money. Sorry. So the hospitals, what the language said is you can present it in machine readable format. What did you say? Oh, yeah. You can get the data. It's in machine readable format. Okay, I'm not a machine. I don't even know what it means. So the point is, you can't, as a member of the public, just go out there and get this. You can't easily say, hey, listen, I'm going to have, hernia surgery. I wonder how much it's going to be because I have an HSA and I care about the deductibles and my policy. America has made it horribly not helpful, not just Vermont. I mean, you can pick on the Vermont hospitals as you should, but everybody's not made it easy. So it makes it really difficult. So we spent a lot of time to do this. And there are literally thousands of CPT codes. I think I'm gonna guess, I think we have like 7,000 to 9,000. I think UVM, given their complexity, has like 25,000 codes. You know what I mean? So, but you should be able to, thank you very much. We've got.
No props.
So when you look at this, this was the old one we did in 2021, but some of our prices, so here's one on the bottom. CT of the abdomen and pelvis without contrast, we charge 1,224. The average is 3,300 and the highest is 5,153. Now, when you look at some of these changes, some of them are not only hundreds of percent more, like, oh, that's twice as expensive. No, it's 5 times more expensive. Sometimes they go up to 900%, if not 1,000%. Now, I know healthcare is very complicated. I've worked in it. I live in it. I've done it all the time. It is way too complicated. And when folks like you and others are trying to fix it, you got to stay focused. If you can't, everything's connected. And if that bothers you, then we'll do what we always do. Nothing changes. But the price differences are crazy. You would never walk into a store to get a cup of coffee and spend $2. Well, that's okay. And then go to a general store in Elmore and they say, cup of coffee, great, that's $22. You'd be like, are you kidding? You'd never forget that story. You're charging me, I get it for $2. You're charging me $22. So some people that look into this realize that this is the beginning of some of the insanity, the price differences. And Copley should have probably raised their rates so that we've been sitting at some of the lowest, but sorry.
No, Leslie had a question.
Yeah, I was just curious, in contrasting these prices, does it have to do with the age of the machine and where it is in its lifespan?
I love that question. You know why? Because healthcare is so interesting. We don't do detailed cost accounting to find out how much you should charge. In manufacturing, we used to do cost accounting to determine how much we charge for wire and cable, how much the workers make, what are the benefits, in a level of detail through time studies. I used to do those. Healthcare, we don't do that. For the most part, it's driven off of the market. Isn't that fascinating?
Mhm.
So when we got a new MRI, we had one of the oldest MRIs in New England. It was mobile. Somebody said, oh, you got a new MRI? I said, yes, we finally got one. Did your prices go up? Imagine your prices went up. A normal, totally reasonable question. I said, no, we don't change the prices. And I go, that's fascinating. You got a very large, expensive piece of equipment. You didn't change your prices. Sorry, it's a dirty little secret. Healthcare doesn't really work that way. It works upon what's the market, what gets paid, what does Medicare pay, what do people pay? But it doesn't go into that. It should, but it kind of doesn't.
Thank you.
Yeah, so this is 21, 22. Here's the next slide. This is the update. I've been doing this for years, so I've been ranting about this, which is fine. Thank you for letting me have an audience. This is 24 estimated. We did this last year for our 25 budget. We're going to update it this year again when we go back to the, so this is a little different. It's got the semi-private room rates up top, emergency levels of care, laboratory services, and then diagnostic imaging. Laboratory was added because our local largest primary care office was sending all their lab work to Quest. They made a quick decision to say, we're going to send it to Quest to save money. And so we ran a bunch of studies and found out that our prices were actually less than Quest out of New Jersey, Camden, New Jersey. So we were very curious about that. So that's why that's up. There are literally, this is not all of healthcare, right? This is only one sheet and you could look at hundreds and hundreds and hundreds of other codes. So this one's interesting because we changed it. Green means that Copley price is lower and whatever reddish means that Copley price is higher. And in this case, we look at Vermont, we look at the average too of all the hospitals. Just taking the straight average, not using a volume adjustment, just if you charge 50 or you charge 20, would say 70 divided by 2 is 35. So in this one, I just have a 87070. So it's hard for anybody to say, oh, I want to go find out how much my lab work is. And it's our fault. We just have not made it easy. And then sometimes when the state gets involved and they do reports, sometimes the reports like this one, only you can see it, right? Nobody on the audience can see this. Anyways, these reports don't actually make it easy for you to understand what the prices are. And you should be able to say, well, I just want to know the prices. We charge $56. I think the highest one there is what? 232.
What is that?
That is the price for a culture, other specimen, aerobic, as opposed to a CBC or a panel. So I'm not a laboratory technician. I couldn't tell you exactly that, but those are the prices for that service. Yeah. So the price differences are pretty great. They continue to be great. Sorry.
So first of all, this is fantastic. We
Thanks.
never get to see this sort of, we talk about the macro and the hospital system. So this is, I'm thrilled with this. I can't, as you're going through each slide,
Yeah.
I am thinking back to just this morning when we were presented from Christopher Whaley, the price variation at various hospitals, Vermont hospitals. You are, well, depending on if you're number 1 or number 14, whichever way you want to classify it. Copley Hospital's price relative to Medicare is the lowest of
All of them.
all of them.
Yes, correct.
So I'm wondering, you were going through the slides with all of your rate increases, decreases, your orders.
Yeah.
I guess number one, I'm wondering if you ever feel, I look at the one close to 150 and I think that is an efficiently run hospital. I'm wondering if you ever feel as though you're being punished for being efficient. And also when you ask for rate increases, the fact that your prices are already so low, a percent increase isn't compounded as if it would be on a higher price. So you're actually, like, for you to ask for 3% more on a really low price and somebody else to ask for 3% more and be given that on a high price, they're going to get more. Because that 3% is going to be more of an already inflated price.
I'm about to cry. This is unfolded perfectly for me. Others are worried about what I'm gonna say. Here, this is what I say to people. I say, listen, if something costs, we charge $10 and somebody else charges 100. They could say, well, that's wild. I say, I'm trying to do the math and it basically works. Well, it's impossible somebody would charge 1,000% more. It's like, no, that's not actually impossible. So let's just go with that analogy. So if I get a 10% increase, which has happened over the past few years, because I'm working really hard to adjust this. Somebody says to me, oh my gosh, Wooden, you got a 10% increase. You must be happy. Why aren't you happy? Like, you gotta understand the context. This is really, and so why aren't you happy? And it's, well, because I charged $10 and I got $1. They charge $100 and they just got $10. They got the entire price. So I'm up to 11, they're up to 111. And it's like, what are we doing? You're right. You never catch up. It's ridiculous. It is like, you could give us, well, here. I'm on my soapbox. This is good. If in 2022, if you paid us average, the average column, it's very simple. Okay. Should be a different color, but what's the Vermont average? If you paid us average, Copley would bring in about $93 million of gross charges, and our operating margin would be $16 million. You hear what I'm saying? If I go back to that, we are working like dogs, and the system is barely sort of catching up. So, having fun, yes. I love working in healthcare, nonprofit. I love working at a hospital. People really do a great job. I work especially hard because the nurses and doctors are saving lives. They're putting up with a lot of stuff. So I try to work as hard as them. But it is a crazy system that doesn't work. It's really so blatantly unfair. I tried to explain this to somebody and they say, well, if you go to reference-based pricing, why not just go to Medicare for all, Joe? Why don't you just advocate Medicare for all? And I said to that person, yeah, that's a good point. I like that idea, but we can't get there. It's too much of a switch. So this is a step towards Medicare for all. You go to reference-based pricing and you say, listen, your prices as a foundational step. And when people describe the complexity, it makes you not make decisions. Because your head hurts and you're like, I can't do this. But so I think reference-based pricing is a step towards fairness, toward Medicare for all, and towards something that's understandable. Because if you have a limited HSA and you're worried about your deductibles and your co-payments, and you find out you had a hernia and she had a hernia repair and you paid 25,000 and her bill was 5, you would be fit to be tied. Just old fashioned numbers, like that's crazy. So the difference is huge. How we get there, it's just going to take time. Let me go through a few more. So in 2021, that's this column, the Copley rank was 12 in terms of how much more people got as Act 53 procedure, the basis for study, needed to get to an average rate where in 2024, we moved to 11, which is great, right? So in 21, we were the lowest, 24, we were the second lowest. To move up one position, we'd need a 6% rate increase. To get the most expensive, we'd need 111. So if you raised our rates 111%, we'd be up there with the others. So there's many ways to look at the math. It's just another way somebody said, oh, that's great. Look at your ranking, right? In terms of who's most expensive. When you look at the RAND data through this, they call it the SAGE transparency data, but it's from RAND. Yeah, we're at 144%. The orange is the state benchmark and then the national benchmark at 253. If you take ours, this is not new. This has been on the website for years. I do this every year. It's just nobody reads it, and I don't blame you because too much reports.
We will now.
Yeah, you go back and look at mine. You can look at my presentation. So this is us versus all the other hospitals. Data is not always perfect, right? And you should ask questions about data, like, does that make sense? If we stop asking about data, then it's our fault if it's wrong, but data is not always perfect. So here's a case where the green is supposed to represent if you have a hospital system price, the green being you're part of the Dartmouth-Hitchcock system, you're part of the UVM system. But if you look at this, you'll see that Northeastern has a green comparison number, and St. Johnsbury is not part of the Mount Scottney is, Porter is. And if you look at this one, Porter's prices relative to their system is significantly lower than the system by quite a bit for Porter. This one, again, it's UVM is the system, but Brattleboro is not part of the system. Brattleboro is independent, they're not part of UVM. So you do find data discrepancies and you should always ask about them and, you know what I mean? Sometimes we have analysts do data and nobody raises their hand to say, does that make sense to you? We should do that, that's important. Here's a chart of total, I can't read all this because I've got total facility plus physician price as a percent. RAND data, state of the lowest. You know, we got good quality, which you probably know because a lot of people come to us for orthopedic, et cetera. Here's one of, you know what we did last year, which really, everybody would say, wouldn't it's the price? That's not what you get paid. And you know, the contractual relationship with Blue Cross, MVP, Cigna, that's all over the map. Jeff Hebert, I'm sure he's out there. Great CFO, knows how to dig and find truffles anywhere. He's so good at his job. He said, Joe, the data's out there. I can get this for us. So we presented this last year to the Green Mountain Care Board. My car still works. The tires are usually intact. But this is Blue Cross reimbursement, and we have this for every insurer. So we got this for Copley as well as every hospital. So A through M, they're hospital names. Nobody has suggested I take the letters off and put the names in, but you know, anybody could do this. So we've got Cigna, Blue Cross, we've got MVP, as well as, I think just those, yeah. So it's interesting. So you could say, well, I know you charge 5,000, but what do you actually collect? Okay, that's not understandable. You just look at each one of the payers to find out. Some hospitals do a better job shaking down the insurance companies. And they get paid a little bit more. Other hospitals don't get as much. Sometimes it's a percentage of your charges, or it might be a fee schedule. So isn't this fascinating? Again, most of our services, we're well below. So this one for Blue Cross, look at, we're green everywhere. So if you go to Cigna, we're green everywhere. For some reason, Cigna pays some hospitals, we're paid pretty well, but we have some red up on the emergency. Isn't this interesting? MVP. So data's helpful. Again, if you're getting a bill and get an HSA or a co-payment or deductible, it'd be great to have the first set of data. And then if the state wants to see who's actually collecting which money, there it is. Fascinating, right? Because I looked at this report, I couldn't get anything out of it that made me understand the issue of what's the price? Why would it be hundreds times more? Okay, I'm almost done. Here's some examples. It says net reimbursement. But there's the rate increase. So here's Blue Cross, the first two under payer, Cigna, MVP. So it's urine bacteria culture, ER visit level 3, CD. So, right, Copley's getting $27, or somebody else is getting $194. You just look at what you get reimbursed. Isn't that pretty surprising?
Yeah.
Is that helpful? Yeah. And if the data is wrong, somebody might fight and say, oh, that number isn't 232, Joe. That's wrong. It should be 230.
Never.
Really? Okay, thank you. Technically, you are correct. Fortunately, it's of no value. So I think this data is really good. Lastly, a couple more. This is an example where level 3 ED visits through Blue Cross. I'm not picking on Blue Cross. Blue Cross is part of it, sure. They're great. We're all in this together, right, folks? So Copley gets $376 for every ED visit. Another hospital gets $1,178. If you look at the M hospital's volume of 3,770 visits, we would get 1.5 million. They'd get 4.5 million. I'm rounding. The difference is like $3 million difference for one level of care out of the 5, ER visit. And that's not to say the other thousands and thousands of others. So I want to leave with this thought. I get this. I'm an engineer. I love systems. I love data. I just love data. I get cognitive overload. We all do, because the system is so complicated. And when you see a thread and you say, we should cut that thread or pull it, like that's not okay. And then somebody explains all the complexity of healthcare. You usually say, Uncle, I give up. I'm sorry. I'm going to go back to anything else. I'm going fishing this weekend. I'll think about it. You run away from it. We do this to ourselves. Healthcare is super complicated. And if we spend all the time learning every single dial and lever, we're not going to get anything done. And we've been doing that for a long time. So I'm a big fan of us going down this road. I've talked about it for years. Green Mountain Care Board has been sympathetic to our plight, so we have been getting increases, but it's just going to take a long time. Imagine if they said, Copley, we're going to give you 320% increase in your rates. So do we get punished for doing good? No, but what the systems do typically is if you're doing really bad, you get extra help. Do you get punished because you're doing well? No, but you sort of get the opposite of that. It's sort of punishment. And that is when people do really poorly, go bankrupt or have huge problems, the state comes in and does what? Anybody?
Helps them.
Helps them. Yeah, we'll help you out. And we never learned that lesson. So Springfield Hospital went bankrupt. You ever see an excellent report going back to Onion to find out why Springfield got bankrupt? Because I've never seen it, and I'm in the business, and we don't even learn from. That's why I can't do your job. I can do my job barely, but you couldn't do your job. So I hope this was helpful.
It was, the chair's allowing me to ask you some questions if you're ready.
Yeah, whatever you want to ask me.
So I am only going to ask 3 and then leave space for others, but
Sure.
this was helpful because it really got me thinking. So you said you're an engineer.
Systems engineering.
Okay, so as a systems engineer,
Yep.
I would like for us to be solution focused.
Yes.
What would you say would be, I heard you mention that reference-based pricing might be an immediate or short-term action, but what would be the short, mid, and long-term steps if you had to think about planning towards providing hospital services as a public good, more as a commodity? Because you referred to Medicare for all, and that's what made me think like, and you said that reference-based pricing could get us towards that or something like that.
I have a list of like 18 items that goes back decades that I've presented to committees and show people, and it gets updated, but there's a lot of stuff we could do. The stuff that I'm interested in doing is not sexy, won't get you votes, it won't make national news, but if you don't make small improvements, we save 1% here. We save 2% of the system. If we don't celebrate small improvements, we're kidding ourselves that we're going to find some magic bullet. So a lot of my suggestions are small improvements that would make things much easier. Healthcare is filled with regulation, redundancy. It is absolutely insane. So if you say, I want to hire a doctor and they're a specialist or primary, whatever it is, you hire them, they have to go through the medical staff credentialing process to make sure that they are of quality, right? So the individual hospitals research data, you got to get original records. There's a whole department that does the credentialing. After you've said they're good enough to work in your hospital, you now have to go through the enrollment process, which is basically credentialing. It's the same thing for insurance companies. Wow. And with insurance companies, you have to get Medicaid, Medicare, Blue Cross, Cigna, MVP, and they're all different, have different rules, and they don't even, it's like, why wouldn't you just pass a law that says, listen, hospitals, once you get credentialed from Medicare, because it's a federal program, Medicaid, we're in control of, we don't give a crap, we'll accept Medicare. You say all the other insurance companies, you have no right to spend time credentialing somebody that went through the medical staff done. There's a million of those ideas.
Like universal credentialing.
Just do it once.
That's a good idea.
We waste money. You can't believe how much money we waste on stuff that is of no value.
That leads to my second question, if that's
I could keep going. Oh, yeah.
Well, this might prompt you to keep going in that direction. I'll ask you that.
I just want to say, I remember when the universal CAQH universal credentialing form came out and it was like 47 pages long. Anyways, keep going.
So-
But it was the same.
I'm going to ask the next two questions as like a group because they're interconnected.
Yeah.
What are the, I feel like it's a quiz. What are the factors that drive up the cost of hospital care from your perspective? What is in your control and what is not? And also Rutland, if anyone else can answer this when it's your turn, because these are the kinds of things I want us to learn more about.
Yeah, I think is in our control is,
What's driving up the prices? Because you're keeping prices lower.
yeah.
So how? Like what, you said there's many little things. What are you doing that others could do? Like, I don't.
Yeah, I wish,
Think about
I'm not somebody that went and read a management book and we're all going to follow, Disney runs my hospital. I don't do that. So I can't really give you an answer that like, we do have a culture attitude. We do keep track of data. We're very transparent about all of our stuff. We don't, you know what I mean? We're very honest. We're painfully honest. And that has been helpful. But there's a lot of ideas. You want to hear another one?
I want to hear as many as
Okay,
you're willing to give within the
This
time.
one will curl your hair. It's been
More?
around forever, and it's got nothing to do with Dartmouth, UVM, Mass General. It's just ubiquitous across America, but nobody's addressed it. If we addressed it as a state, that would be interesting, but we don't. We tend to want to save the world. So many people go to a small hospital. You got a motor vehicle accident. We do we're doing test diagnostic and lab work. We turn the new phone, it talks to me sometimes. It says settle down. I don't know what it means. We'll do a CT and we'll transfer you to an academic medical center. This happens everywhere, all across the country. What does the academic medical center do when we get you packaged up after a motor vehicle accident? What do they start doing? Anybody?
Same test.
Yes. They repeat the test.
Same test.
Same test. They're like, oh, we need to get an update on this lab work and that. We need to do another EKG. We need to do another CT. We're going to do another MRI. This happens all across the United States of America. It's a joke.
Yeah.
Why does that get done? Because
They don't trust the.
They want it.
No.
Is it a clinical guideline?
That's
They
true.
don't.
They don't.
But is it a clinical guideline or is it?
No, this is the main reason. This is the attitude. Okay,
Thank you.
that's not on record because the stenographer can't, anyways. So they do that. Now, if there is concerns about quality, I get that. If you say, we have concerns about quality. The way to solve this is to say, insurance companies are not allowed to pay or not allowed to ask for it be paid for a repeat test from a smaller hospital unless that hospital fills out a quality form. And that form says, listen, your CT scan was not sufficient. We have a 160 slice CT, you have an 8 slice CT. The images and what you did so that at least we're obligated to say, we want to get paid. And here's the feedback to the small hospital. None of that happens. So people just sit there and say, well, this stuff's not good. They don't know what they're doing. They shot the wrong films and who learns? And what happens? Everybody gets paid. And it's like, oh my gosh, it's easy to fix. Just have that requirement. You have to step up to the plate, fill out the form and make sure you tell Copley Hospital, North Country, whomever, this is the concern we have with your test results. How hard is that? And this stuff happens everywhere. Mass General, everybody does it.
So
But nobody's got the nerve to step up to the plate and say, why would we do that?
can I make another request before I give up my time asking questions?
Sure.
This is very helpful to me to hear like the specifics. If you would consider, I know you don't have a manual and you're busy, but like if you've given the presentation before about what the 18 things are, if you would consider sharing a list with us and you don't even have to sort them, or you could be like, here's things you could do right now in this bill. Here's things that a working group should look at. Just because I think we need to do as much as we can right now. And if there's little things you think we could do in this bill and not wait, that'll start saving us money, why not?
I will cause people heart attacks. They will stress out because I run at a particular pace. I see a lot of improvement. That's how we do well. And, but we could do that. You know that the billing office at most hospitals are divided up by the billers that know the exact type of billing system. So if you're a Blue Cross biller, you specialize in that. You're very good. You understand that. You do workman's comp, or you do Medicare, or you do Medicaid. They're all divided up. So if you ask Dartmouth or UVM about their billing staff, billing is so unnecessarily complicated. We should just all bill. It's just that easy. Everybody should just bill the way Medicare bills. Exactly follow their manual.
Yes.
Do not allow anybody to change. Medicare has a manual that covers birth to death. Medicare is the biggest game in town. Why the hell you would allow insurance companies to try to justify the fact that they add value with a different way? Stop it. And you know what? All the billing staff would actually come down to one skill set and you'd save a bunch of money. To me, that's damn exciting. Anybody else like, oh my gosh, we can't do that. That's how bad the system is. Thank you. I am on medication. Just kidding.
I appreciate your enthusiasm and thank you for
Yeah.
Any questions.
Any questions? Sure.
We did do some work around aligning to Medicare last year, so hopefully that will.
You gotta do it exact. It's gotta be exact. Same manual. Medicare doesn't change it. We don't change it. That's how you save money.
That's what we did. Okay,
Hasn't started yet.
any other questions? We want to have, yeah, you're right, it hasn't
I
started
just have a
yet.
comment.
Sure.
I represent Enosburg, Montgomery. We hear great things over there. We see great things over there. So thank you.
Oh, yeah, great. Thanks for saying that.
Wait,
You've recently opened up a new orthopedic center.
Yes.
This is like number 3, is it?
Number 2. We have 2 offices, yes.
So things are good in orthopedics, I guess, financially.
Yeah.
Moneymaker?
Oh, of course. Yeah. So in all of healthcare, there's a line which means you break even. This is pretty simple. You find it in the People's magazines. Pretty simple. Here's the line. These you make money off of, and these you lose. But as a healthcare system, you have to do both. You know what I mean? You can't say I'm going to just drop ones that I don't make money. You're nonprofit, so you have to sort of look at the country. Orthopedics and any surgery in an OR usually makes money, usually. Yeah, so orthopedics is up there, cardiovascular surgery, there's a whole bunch that are up there. So yes, we do a lot of orthopedics, a ton. And it doesn't show by our facility or our staff, like we do so much, it's surprising how little we get paid. So we do well, we're lucky.
So there are no other hospitals that are saying Copley's doing too much with orthopedics?
No, everybody wants us to do more. In fact, I've had discussions with state people quietly saying, why don't you do more? Because you're so cost effective. Oh my gosh, you'd be the best. And it's just, it takes time. Like, you can't just ramp up that quickly. So we built that building down in Waterbury, and that's pretty much full. We're really, really busy. And our quality's great. We do a good job. People do us, but thanks.
Leslie, I really want to get to Judy and we're backing up Commissioner Hawes.
Okay,
a little bit.
well, I just wanted to expand on what Woody said, because I'm looking at the Acts 167 report in regard to Copley. And one of the things they recommended was to go deep into orthopedics and create a regional center.
Yeah.
Is this work related to that? We were doing it ahead of time.
No, we were doing that ahead of time. So we used to have an office in Waterbury, right next to the restaurant there. I'm blanking on the name of it. The Reservoir, yes. And very small, and about 70% of the visits were from all over the state. So they get to the interstate, get to us. So we built a new one a mile away. And we have a footprint to expand that. It's 10,000 square feet. We could put another 10,000 square feet, but we don't have the money. Everybody wants us to do more because we're so cost effective. Even if you raised our rates, 20% would still be like the most cost effective choice.
So
But
that's,
people don't even know how to see that. Oh my gosh, go to Copley. You could save hundreds of thousands of
the
dollars.
Center of Excellence idea that was coming out of
Yes.
Oliver Wyman seemed to tag you as a Center of
Correct.
Excellence.
Yes.
So is that
That's
coming,
it.
that's happening?
It's been happening for decades, so it's been going on for a long time. They just recognize it, gave us the label, which is really nice.
Mhm.
So
Mhm.
it's not like we got better because they labeled it. You'd like smaller hospitals to do that. When I worked at Gifford for 16, 17 years, two things that we did very well, which are amazing, is we were doing a ton of cataracts. We did more cataract surgeries than you can imagine. Jack Singer was the doctor from Dartmouth that moved there. We had two doctors, Chris Soares is the other, and we did a bunch of babies. Because Gifford was the first hospital back in the 70s that adopted midwives, actually put them on the medical staff, employed them. In the 70s and 80s, people said, you people are crazy to do that. And now it's standard, but Gifford for many years. So it's good to encourage small hospitals to develop centers of excellence. Otherwise, they won't survive, you know?
Just one, you have no issues like attracting and keeping orthopedic surgeons.
We have such a good team that we just hired two. We hired our first female orthopedic surgeon. Didn't happen, but we
You have
did that,
great
and we
rep-
hired another young, really, both of them have parents that are doctors, and we're really happy. So we got a really good, respected team. They love the work that they do, and they just do a great job.
You're
I'm
very well respected in
Yeah.
there.
I'm very humbled, and it makes me do my job because they work so well. I feel like I need to be as good at what I'm doing.
But it seems like to me that there's other hospitals out there that could be doing orthopedic work, that should be making more money than what you're charging. And in a way, they'd be saying, we should get rid of Copley's orthopedic centers and move them to our facility.
That's a good problem. It is an issue, when somebody needs a service. Right, yeah, that's funny. I've never heard that stated like that, but now I'm paranoid. Thank you. Definitely not sleeping tonight.
I'm sure you've heard it before.
Yeah, no, not that. No, I've never heard that. Well, maybe you'd be.
And I know we need to get to Judy. I just want to flag, because it's a conversation that I'd actually like to have in the future, is one of the very first things that you mentioned was that you don't actually have primary care. And that is something that I would like to talk about at another point.
Yeah.
Yes, it's super important. That's the foundation of all healthcare. I'm in a hospital, but if you ask me what's the most important service, it's primary care.
Yeah, and I've been wondering about where primary care should be. understood it. What is a hospital?
Thank you. Thank you.
Thank you, thank
Yeah,
you
thanks.
so much. That was fantastic.
Thank
Yep.
you.
Hi, Judy. Sorry, we got carried away. Let's move down to the end of this, other end of the state.
Sure. So thank you. Just get my screen set here. So good afternoon. For those of you who don't know me, I'm Judy Fox, President and CEO of Rutland Regional Medical Center. Rutland, we're the second largest hospital in the state, but we're the largest employer in Rutland County. And we take our responsibility seriously. Have the privilege of caring for about 60,000 community members. That's resulting in about 6,500 inpatients each year. We care for more than 100,000 patients in our clinic visits, our clinics, and provide testing services to about 300,000 different encounters. To do this, we employ about 1,800 employees, 140 of which are physicians and advanced practice providers, but we have credentialed, so physicians who have the ability to come into our hospital and care for patients. We're around 375 providers. And just to tag on to what Joe was saying, we do not employ primary care either. Our primary care is mostly structured within an FQHC, although we do have a handful of private docs and their own businesses. So our physicians that we employ are specialists, and we employ almost all specialists, but rheumatology and dermatology. Every chance I get, we say Rutland wants to be collaborative. We want to work with state and community agencies. We think that's what's in the best interest of Vermonters. And we think that that is the solution to balance risks and promote sustainability across both providers and payers. So I was asked to testify this afternoon. Thank you for that. And I was asked to testify specifically on S-126 sections 4, 5, and 6. So I am going to narrow my conversation with you today to those 4 sections. Overall, the overarching theme is we don't believe that there's anything too egregious in S-126, but we think it's redundant. And what we're offering are solutions or thoughts around how to get at the information that's already provided so that we are not promoting additional administrative burdens or costs within the system. And we're also trying to really focus on a single source of truth, which in and of itself, without that, can drive costs up. And where we really want to head, and I'll end with that, is reference-based pricing. So without any more delay, jumping right into section 4. So section 4, item number 7 on page 9, and I'm going to be very direct and speak just to S-126. If you'd like me to give thoughts, outside of that, I'm happy to do that. But I wanted to be clear with what the ask was, and so stay close to that. Section 4, classification of employees. So this is a requirement that the hospitals would provide information that looks at administrative versus patient care. As stated, we feel the language is too ambiguous, and here are some reasons why. The definition of administrative is too gray, and I'll give you examples. Nutrition services, employees who sterilize surgical instruments, employees who maintain medical records or schedule and register patients for care. Our quality department works behind the scenes, but really directing inpatient care. What bucket do these employee classifications reside in, and how do we make sure that there's consistency and equity in reporting that? But I will tell you that we do have a reporting requirement with the Green Mountain Care Board. I'm not sure if you're aware of the hospital guidance and reporting requirements booklet. But certainly, there is a requirement for this type of data to be submitted by hospitals. And we, as a hospital in Rutland, honor this and do provide data. And for your reference, this same or similar data is reportable to Green Mountain Care Board as part of the budget narrative, and it's within Section C of that reporting requirement. Same thing with base salaries. We're not saying we shouldn't communicate or provide information. We're saying it's redundant to what we feel is included as part of our regulatory requirement within the Green Mountain Care Board. But we also believe that this information, and we do have this opportunity with the Green Mountain Care Board, this information should not be overly public. It needs to be held tightly because it will create competitiveness issues and recruitment issues and could actually serve to drive costs up if we're all communicating kind of where our salaries are. You do have the Rutland response, and I just included that so that you can see what types of information we're providing in terms of executive comp. We have a philosophy. We benchmark to the 50th percentile. We don't have incentive or variable compensation methodologies. It is your base salary. And we use that information. And actually last year, I'll just share with you, we withheld some market increases for a couple of executive positions here at the hospital when they were at the 50th percentile, and that benchmarking did not justify further reimbursement. So our solution to you is to stick with what's working, the Green Mountain Care Board, specifically the budget guidance, the hospital reporting requirements within the other operations and the salary. Also knowing that this information is publicly available on the 990, albeit there is a bit of delay in when the 990s are published. On Section 5, we are supportive of revenue being excluded from primary care, mental health, and substance use disorders. But we think it should go just a bit further. If we're going to exclude revenue, we also need to waive expenses. Otherwise, we're going to risk looking to support services that aren't fully supported by cost to provide care. So I think it's just a small tweak in the language there. Moving on, Section 16, page 12, again in Section 5 of S126, redundant to what we've just talked about, base and variable compensation. Again, this is all supported and reported within the Green Mountain Care Board, and I would suggest that we use that mechanism and not build redundancy. But I'd also suggest that we stick to the methodology where we're really using benchmarks to drive compensation decisions and remain committed to that and let the benchmarks drive compensation levels and not salary spreads, because I think we're going to get ourselves into some difficulty in retaining and recruiting staff. Page 12, which I believe is item 17 within Section 5, is classification of employees. This again is redundant to where I started the conversation with you folks just a while ago, and think that there is a pathway and a reporting requirement with the Green Mountain Care Board there as well. Moving on to page 14 of the bill, and this is item 1B around global budgets. We are supportive of global budgets and think that this is the type of change and innovation that Vermont hospitals payment systems need to look to create. But we want to just wave some caution here. As we worked with AHS and the Green Mountain Care Board with their application to the Centers for Medicare and Medicaid Innovation, it is projected and known that Medicare reimbursement in aggregate across the state of Vermont is about $350 million less than other states. And we just need to use that information point as we begin to design and consider how to move forward in these payment reforms. Again, on page 14, this is section E2. And this is around reverse CONs and keeping services in our community. We are an advocate and a supporter of keeping services within our own community. But what we need to understand, and I'm going to share an example with you, is there are circumstances beyond cost that are risking program sustainability. So here in Rutland, I actually have 2 specialty services that we have one physician in each of the services providing the care. In one case, and this was 2 years ago, and the physician has been extremely dedicated to our community, the physician has a desire to retire, and we've been recruiting for 2 years and have yet to be successful on a recruitment. There is the likelihood that this service will need to go away in Rutland if we cannot recruit. Why are we having issues with recruiting? In this case, they want access to ORs, and they want to be able to use a couple of rooms and go back and forth. They have some needs and specialized equipment, think robotics. And then there's some perceived limitations on salary, along with the fact that we're just a small rural community. Again, our solution is we should be talking about this early and often. We should be working with the Green Mountain Care Board, and this is part of the Green Mountain Care Board budget, particularly in the budget narrative section in the background, where we have to provide and outline any changes in service. And so we think that that is a good practice and should continue that there within the budget guidance.
Judy, can I interrupt you really quickly? Can you go back to something? Because we went over it really quickly, and I just want to explore a little bit. You were talking about in the global hospital budget, as identified through the work of AHS and Green Mountain, we estimate that Vermont Medicare reimbursement rates in aggregate are $350 million less than other states. Can you explain what you mean by that? And then can we explore why we think that's happening?
Yes, so this was confirmed, evaluated within Green Mountain Care Board and AHS. They've had a number of consultants working on their behalf where we look at Vermont reimbursement compared to other states. And that the magic number, if you will, when we looked at the services provided in Vermont and the services provided in other states, Vermont was about $350 million below in reimbursement as to other states. There are a myriad of reasons, I'm sure, why. Some of it is that Vermont has been dedicated to looking at cost control and working through OneCare and other mechanisms on reimbursement rates and total cost of care that has been managed by the Green Mountain Care Board, and we've been somewhat successful. And so what we're seeing is some of that success coming in and lowering rates for Vermont. What we need to understand, though, is that will shift benchmarking a bit. We can't just look at another state to say, well, they're getting 250 or 200 or whatever the number is, percent of Medicare, when their Medicare base is a bit different than what we see in Vermont. So it's not a showstopper. It just means that we need to be very articulate as we consider what these types of payment opportunities are within global budgets, or quite frankly, within reference-based pricing methodology.
Wouldn't this ultimately be a result that our population is just a little healthier than other states?
One could say that. That would take some opportunities to look at data sets and look at acuity. I would not, that's not where I would jump to first, for sure. And I'll tell you that in Rutland, we've seen an increase in acuity across the board, not just with Medicare, with patients who are just sicker. And I know that sounds like an excuse. It's not. It's something we are we're focusing on and trying to understand how we respond to. And some of it is just delayed care, some whether from COVID or access to primary care or chronic care. So long story short, I don't know. It's something that would need to be studied.
Thank you. Oh, I think Leslie wants to.
Well, I'm not sure if my question is for Judy or for you.
Okay, well, let's ask the question and.
Okay, because you mentioned the issue of redundancy, and you've been involved in writing this bill, and I'm wondering who, I don't even know how to articulate this. I mean,
Just want to be clear, I was not involved in writing this bill.
so I was kind of imagining, this is my imagination, clearly, that we wouldn't be putting in things on top of things that were already there if they're already there. So I just want to understand how to explore her concerns about redundancy, and maybe that's someone with the Green Mountain Care Board that we could help. Yeah, in those places where she says it redundant, like adding more layers makes no sense. But if the system's working, but it happens to be in this bill because it's working, then that's okay. So that's what I'm trying to understand.
I think that's a great question for Green Mountain Care Board.
Okay, so
We can
let's put it on our list.
Explore where there's pieces in the bill that
She mentioned like 3 different places she thought was redundant.
and great written testimony.
Yeah, very
And-
helpful.
Thank you, Judy. If you want to go ahead and continue.
Sure. So waiver and reduction of services. This is page 15, item number D. So this is really linking the, again, an opportunity for exemption from reporting requirements when we are shedding, shrinking, eliminating, whatever the verb is you want to use, services. And there has been an acknowledgement that, hey, by the way, Act 167 is actually promoting some of these service reductions, so we shouldn't kind of double jeopardy, have it come out in a Act 167 report and then have to have hospitals explain why. And while I agree with that, what I want to make sure, and I have an example and I have some data to share with you that doesn't get lost in this translation, is although a service may be up for, elimination or reduction, more times than not, that care is still needed by patients who were receiving cares in these communities who are shuttering or reducing services. And we need to make sure that we don't have a false sense of security that by closing services, we're reducing costs. And I have an example to share with you. So Central Vermont, they closed their inpatient psychiatric unit back in January. We happen to be situated, fairly close to Central Vermont. What we have seen since January is 40 patients, and it's probably 42, 39, somewhere in the neighborhood of 40 patients have come from the Central Vermont service area and are receiving or have received care at Rutland Regional Medical Center for inpatient psychiatric services. That's not a savings to the state. That's a transition of care from one health service area to another. So my only caution to you is to make sure that as you're thinking about closures, that you're thinking about both sides of that. And is there a true reduction, or are we just transferring costs? In this case, it's to a Vermont hospital, but it very well could be to an out-of-state hospital as well. And so that's the point there, is let's just make sure that we're careful in not realizing or thinking we're going to realize savings by closure of services. And so our solution there is, let's just look at both sides and in the bill language. And then in section 6, while I was invited to offer testimony and feedback, we're not part of a network, and I don't think Rutland is in the best position to be speaking about network activities. So we'll just decline any opportunity to offer comments there. To end with, where I would like to focus, and somebody asked, what's the midterm, long-term goals or projects, or how do we get out of this state we're in? Rutland supports and recommends reference-based pricing. We think that this is a plan that we need as healthcare providers, that payers need, and that Vermonters need. Unfortunately, it's not a quick fix, but I think we can make year-over-year gains and get to where we need to be if we're committed and develop this pathway together. I think it needs to be, I don't think, it needs to be full stakeholder participation. And by that, I mean state agencies, payers, providers, and we need a goal to work toward understanding there are steps there. Rutland, now there's been a lot of focus on 200% of Medicare rates. If Rutland were to do that holistically, we would lose about $50 million of reimbursement. That is too big of a chunk to take in 1 year, and we would risk severe program closures that provide a significant benefit to our community. I'm not saying that that's not a goal for the future. I'm just saying we need to make steps to get there. And I'm offering Rutland's support to help with the design and kind of the thought process behind what that looks like. This is also another area, just be careful. Rutland or Vermont has $350 million less in reimbursement that will impact multiples as we're comparing against other states. So that's what I had to share with you today. Happy to take questions.
Any questions for Judy? Or
Judy, in your analysis or your thinking, if it's gone this far, how long would you like to see the ramp of a reference-based pricing process be for you all to make the necessary changes to the financial impact it would make? You looked at that at all?
So I don't want to sell something that I don't have a lot of information on. But we think that the process is to start small with a pilot group to really learn from and continually kind of add more volume there. And so that's in the scope of who would be involved. And then in setting the multiples, I think there's a pathway down. We're not going to get to where we want in year one, but that doesn't mean we don't have a plan. By way of example, so I threw out Rutland, would have to cut $50 million in expenses. In the last 3 years, and I'm proud to say Rutland has the lowest cost trend rate in the state. But that's been a lot of hard work. And over 3 years, we've cut about $10 million. If you look at that based on what a percentage of revenue looks like from like a commercial payer, that's about a 6% savings to commercial rates over the 3 years. So you can kind of use that to proxy to say, what does that look like if we were to go after this in a stepped approach?
Great, thank you.
Daisy has a question.
Judy, do you have any concerns, or did anything cause you pause around the data integration pieces and advancing that are in this bill?
With Vital?
Yeah, I mean, I don't know if that Vital specifically called out, but I know section 13, data integration advancement is mentioned. Did any of that concern you, or what are your thoughts on that?
Yeah, so data is critical and not to use the Vital term, but vital And it is something we're concerned with the closure of OneCare. So we are getting claims data from OneCare, not just for Rutland hospital, utilization, but for our community and any patients that are attributed, if you will, to the Rutland Health Service area. Without that data, we are going to be challenged in being informed as to, where we're losing some care, where there's some redundancy in care, where there's not follow-up in care. We look at that in terms of, who's engaged in primary care, who's had a well visit, who's had a visit after they've come to the ED. We're looking at our ED high utilizers. Do they all have primary care physicians? If not, let's work with them. So we are supportive of any measures that will allow hospitals to continue to receive this information, to make care to make decisions not only for their services here inside the hospital, but for their community.
Thank you.
I just have one question, and sort of building a little bit on Lori, because you're talking about the timeline and you're talking about like reference-based pricing and this collaborative process that all stakeholders and an on-ramp, and it should be phased in and all of that. Maybe a rhetorical question. If insurance rates, let's say Blue Cross Blue Shield's rates go up 20% next year, and we lose the enhanced federal subsidies, do you feel as though that will have an effect on the number of Vermonters that will be uninsured? And will that have an effect on Rutland's budget?
Oh, sure. So we're all watching the federal level, right? It's nerve-wracking trying to understand where it's going to kind of sugar out. But any impact from loss of Medicaid funding is going to impact how Vermonters receive care and how providers are paid for care. And so I've seen different estimates around, what the loss of Medicaid could be. I think the work exemptions in and of itself could end with like 7,000 to 8,000 Vermonters losing Medicaid. And then you've got, the Medicaid expansion. So I wished I had could kind of rattle off to you, if this happens, this is what the impact to Rutland will be. We're watching that work closely. All I can tell you is it will be significant. And there are only a couple of levers that you pull, right? And it's looking at services if we don't go to commercial rates. And I agree that commercial rates are not sustainable.
We need to get to Commissioner Hawes. I could ask a million other rhetorical questions. But when we're talking about the timeline, everything right now, that if we do not have a mechanism to change it, every single catastrophic thing across multiple layers in our healthcare system will have an effect on not only Rutland Regional, but on every single facet of our healthcare system. And I'm just not sure the timing of this is.
Yeah, it's not anything that we want to step back on our heels on, for sure. It's going to take full commitment. But what we don't want to do is rush into some of these decisions and then live with bad outcomes because we rushed too quickly. And that's where I'm offering Rutland's assistance. And I'm sure every CEO in the state is also thinking about ways in which they can also provide support.
Thank you. Thank you so much for joining us today.
Sure.
I think we are going to shift to Commissioner Hawes, who's probably standing out in the hallway.
Thank you.
Thank you.
Thank you.
Want to take a break?
Quick, just go ahead, real quick. Oh, just go. Oh, blame you.
Take a break.
Uh,
No, we're not. We're gonna stay live. We're just gonna wait for people to come in.
We have 6, so we're good.
Hello. We're still live. We are still live because apparently there's problems going in and out, so. So we thank you so much for waiting and I know that this is we get way over. So we cannot get.
Beyond that.
That are, yeah.
Excuse me, and all of my electronics.
You were,
Don't have it.
I'm assuming your presentation is on our website? Can you send it to? It is, okay. So we will follow along on our own devices and anybody watching.
Got more?
Oh, more?
I try to bring new stickers every time we come.
Maybe we haven't seen you in, it feels like months.
I agree.
We just decided, let's do a walkthrough on something that we have to have Commissioner Hawes come in on, just so we can see her.
Happy to be here.
You sure?
Yeah.
I want your sticker.
I am also going to, you sent the new Zoom link, is that?
Yes, but it's not.
Oh, okay.
You just get that thing that says something about Zoom? There's something wrong with Zoom.
Yes, there is something wrong with Zoom, but I think we are live. I think people can see us. It's just that if we get out, we won't be able to get back in.
Okay. And we have folks trying to join.
They might not be able to.
Oh, so you will just use
So it's just you.
No co-pilot.
Well, the division of substance use was gonna be my co-pilot, but no. You can always come back.
Can you
Wait
close?
3 months for that, though.
We can get started. Oh, I didn't know if I was waiting for.
Just would it.
3, 4, 5, 6. We're
ready?
ready.
Okay, I like it. Good afternoon, Emily Haas, Commissioner for the Department of Mental Health. Thanks for having me here today. We had planned to have some joint testimony this afternoon related to this presentation with, in partnership with the Division of Substance Use, which is a part of the Department of Health. So I will do my best here, and if there's questions specifically related to the substance use residential system, we can come back and address those.
Oh, yes, I'm sorry. We're also, see, now everybody gets to see the behind the scenes when we're usually not on live and it's not pretty. We're shifting gears back to S36. I'm sorry, I should have said that.
Great.
Go ahead.
Sure. So what you would be seeing behind me is just a quick snapshot. You all have seen this slide about our crisis system of care, which starts with a person who's in crisis, the 988 lifeline, also our mobile crisis response, alternatives to emergency departments, and then another step in the crisis continuum are our crisis beds, which came about with Act 79 after Tropical Storm Irene, and combining those with the Public Inebriate Program, which is a program that's currently overseen by the Division of Substance Use, and it serves individuals on a voluntary basis who meet the definition of incapacitated and are able to be served in a PIP bed, as well as assessed and referred for additional services. So within S36, there's a proposal to begin combining the public inebriate program with our mental health crisis bed system. We are embarking on that in 2 phases, which oh, so weird not to do this without my visuals. So we're embarking on that in 2 phases. And so I'll go through the different agencies that we're targeting. But public inebriate programs are dispersed throughout the state. And it's very similar. I do have it in front of me, but I didn't know that you did. Okay.
We have it.
And in front, you got it. Okay, so I am on slide 3.
I'm glad I pointed.
And so our hope is to really look at what our current resources are and put into play a more efficient use of the delivery of those services. The PIP program has struggled over the years, mostly because it's not necessarily staffed for a 24/7 response, but it requires a 24/7 response. The mental health crisis bed system is fully staffed 24/7 response. Very similarly trained staff, and allows us to, instead of a community member having to choose what kind of crisis somebody is in, they just present at the door and the helpers will decide where that person is best served along with the person who's in crisis. So on slide 4 is what the current locations are for the public inebriate system. So Washington County Mental Health, Claire Martin Center does assessments. They don't have a bed per se. If they need a bed, they typically are referring to the public inebriate program in Washington County. Northeast Kingdom Human Services, there's a specific bed in the St. Johnsbury area. And then there's 5 beds with Recovery House in Wallingford, and then 1 bed with United Counseling Services.
Alan?
Can I ask why we're beginning to do an inebriated program with mental health and beds now?
Yeah, like why are we deciding to
Why are
try
we
to combine
deciding
them
this
now?
Yeah.
That's a great question. As we move to a more co-occurring system, it made the most sense after we rolled out 988, which is a co-occurring response, substance use and mental health. Enhanced mobile crisis is also a co-occurring response. The evolution of those, as well as the struggling of the PIP programs, really made for a great opportunity to take a look at combining those as we continue to enhance the co-occurring system.
Just to follow up numbers, have you got the data that says you might be looking at so many of these per month, per year?
Like so many folks who are interacting with the public inebriate
Right.
program. DSU does have that data, and so we can have them provide that to you. I will, when they presented that data last week during House Human Services, most of the public inebriate traffic does happen in the Chittenden County area. And then from there, it does look different depending on what area of the state that you're in. But they can provide more succinct data points for that.
Can you help ground me in really understanding who we're talking about? Because
Sure.
my understanding, correct me if I'm wrong, is that someone who's publicly inebriated is someone who is intoxicated. They can be on drugs or alcohol. More often than not, they're probably picked up by law enforcement, and law enforcement, not being healthcare providers, can't really tell if it's actually someone who's intoxicated or someone who's in the midst of a mental health crisis. But regardless, they're law enforcement. So if you're in Chittenden County, you're not able to take them to a public inebriate program because there isn't one.
Correct.
So they are going to a correctional facility,
They're going to an emergency department first.
an ED.
Yes.
Okay. And then can you walk us through what happens in Chittenden and then maybe, what happens to the individual, both in terms of like, if they're inebriated versus if they're actually presenting with a health condition?
I can't actually, because I don't necessarily oversee that component of the system. But I do know that DSU could, or the hospital itself. From the non-hospital response, an individual, it's voluntary, so an individual could walk in on their own, a family member. And the original idea around public inebriate programs was to decriminalize public intoxication. And so it provided an opportunity for individuals to detox or withdraw from whatever they're on, which historically had been alcohol, if they were safe to do that.
I got another one. So you just said that would bring them to the emergency room. Now, if I'm the local sheriff and I pick somebody up, first of all, there's going to be a responsibility of there. Do I bring the person home or do I automatically got to bring them to the ED?
You'll have, I'm sorry, I don't oversee it, so it's hard for me to answer that with factual
Okay,
info. Which was why we brought along DSU. So it's unfortunate that they're not able to dial
just to
in.
follow up, at the sheriff's department, they just want to drop them off. Well, according to, listen to some of the hospitals, they can't let them go until there's a place to go.
Yeah, so there's there's a few components to S36, and one of those components is a repeal of law enforcement being able to transport someone to corrections if there is not a safe alternative for that person to be held for that 24 hours, 23 hours. And so part of S36 suggests that we repeal the sunset because there is not a safe and secure place for an individual to go who is experiencing that public inebriation, but are also a danger without having to have charges pressed against them. And so what happens now is that corrections can hold an individual in their booking area, so to speak, if there's not a safer alternative for them to go. What this would provide, it doesn't solve that, but it provides more opportunity for a bed to go to statewide. And we have a mental health crisis system that has open beds in it or within the system. And so this is an opportunity really to expand access, but also know that there will likely be times when somebody is too intoxicated and aggressive with that intoxication. And so we also don't want them to pick up charges unnecessarily. So that's part of the repeal question, the repeal ask in this, which would allow for sheriffs to take someone to a Department of Corrections facility if that's indicated. DSU does have some data around how often the Department of Corrections is used for folks who are interacting with that public inebriate system. And so that's something that you're interested in. We could have them send that along for the committee to review.
And I realize you may not be able to answer this.
I'll do my best.
Maybe you.
Without getting too far.
Maybe you
over
and
my
I
skis.
should go and do like a ride along or something like that. When somebody if law enforcement brings someone to an emergency department, are they usually just assessed? And if they're assessed as being medically stable, but still inebriated, are they then discharged from the emergency department and brought to a correctional type facility?
I believe if
there's
that's
not
the
a-
only, yeah, if that's the only,
They're not like.
more appropriate opportunity, I don't want to say opportunity, I said that last week, and it's not opportunity. If that's the only appropriate placement.
I just want to ensure that there is a place from the emergency department because that is not the appropriate setting for.
Currently, without the repeal, after the end of June, that place wouldn't exist.
Okay. Seem to have enough people boarding in emergency departments. Wendy and then Tupper.
We're in
Didn't they just Didn't the builders come out of, you said that they're taking, there was a timeline, I think at the end.
Yeah, so it's F-36 has the sunset of the, sunrise. I don't know, the repeal of that, which does expire at the end
Yeah.
of this
So
fiscal
now
year. Sunrise, the sunset,
the corrections is the appropriate place.
for some folks.
Okay, yeah. It makes sense. I mean, if there was like a holding jail or something would be better.
A lot of states do have, we don't have a jail system
No.
here. Ours is a prison system. And I think, you know, certainly we don't want people to be in a prison facility
Yeah.
unless they need to be there. We also don't want to, we also want to decriminalize that substance use, and building a secure setting in to replace is also something that we haven't been able to do either. So.
Okay, thank you.
Topper?
I just want to bring something up and then have you react to it.
Okay, I'm ready for it. I think.
We heard testimony that, we shouldn't mix
Mhm.
inebriated people with people with a mental health crisis. The only place I think that can happen based on where the beds are is in Rutland.
To separate out.
Is that,
I think that is one train of thought, that you're not able to mix it all. I think that testimony came out of the Chittenden County area, which does experience a different substance use issue. I'll also say that the combination of the crisis bed and the public inebriate program in Chittenden County happened in response to a crisis situation during COVID or shortly after COVID. And what we're proposing is to have an opportunity for a phased-in approach that has the supports of the Department of Mental Health and DSU when it's not in a crisis, so that we can be thoughtful about how to support staff, but also the individuals receiving care within the facilities.
the other piece is you mentioned that people go into the emergency room and then to an appropriate place after that. You can correct me if I'm wrong. My understanding is when people go into the emergency room, a lot of times they're waiting around because there is no place to go. Is that still true?
In the context of this conversation, it could be, depending on what the individual's needs are. And I would say that's not necessarily untrue for folks who are experiencing a physical ailment when they go to the emergency room as well. So what I will say is that folks can come to the emergency room and get screening and assessment and referred out to where the appropriate placement is, but we are really attempting to divert folks from an emergency department if they don't need to be there. And this isn't necessarily a case where folks need to go into an emergency room to get assessed for that level of care. That can happen somewhere else.
And how do you, out of curiosity, how do you do that? How do you try to keep them out?
Yeah. A few things. One is a culture shift. I think as humans, we are sort of just geared to going to the emergency room when we're in crisis. And so we've implemented 988 in large marketing campaigns for folks to contact 988, our enhanced mobile crisis marketing campaign, so that folks are moving away from that instinct of going to the emergency room if it's not a true emergency medical condition issue, and that we have other resources to serve folks in their community where they are. So that is a culture shift, and a programmatic shift. And I think this committee has done a really great job at supporting us and investing in those programs.
And you feel that's working?
I do feel the shift is happening. That's from my lens and how I experience it. I'm sure others would say, no, it's as bad as it's ever been. But we are seeing the numbers start to decrease from people going to emergency rooms. We're seeing the Chittenden County urgent care really serve people well. We're seeing the 5 other urgent cares that have come online serving people well, especially when that's like with Northeast Kingdom Human Services, when that's combined with a crisis bed opportunity like the front porch.
And just if you bear with me one more.
Okay, Brian's next, and then Daisy.
We just heard testimony that people from central Vermont, since they got rid of their 5 beds, are in Rutland now.
We did have a meeting, the department folks did meet with Rutland yesterday, and we are hearing that individuals who have central Vermont addresses are showing up more to the emergency department in Rutland. So what that tells me is that we need to pay closer attention in working with the Central Vermont Medical Center, Washington County folks, because CVMC still has psychiatry in their emergency department, and they also have an urgent care. And so we're missing getting into people's knowledge base that they don't need to go to Rutland to do that. There are other services that they can utilize without going there. But we are meeting closely with the Rutland team, who is also reaching out to the UVM network to talk more about that too.
Brian.
So I appreciate what is trying to be done, because without becoming a witness, I will just say that there's a gap. There's like a missing piece right now without the services that used to be provided by Act One and Bridge. Is that what it was called? Act One Bridge. I don't know what they are in any other parts of the state, but that whatever that was called, the detox, I can see if we're trying to create parity, I can see why you might be looking at the partial hospitalization. I don't know if they still call them that.
Not necessarily, but I know what you're saying.
Yeah, it's like these programs that, I don't know what you call them here. Sorry if my language is sometimes
That's
out
okay.
alignment, but that's what they used to be called, I think. But I think it's not really.
There's still medical components, nursing components, so it's not 24/7 nursing care.
Right. So
It's not a hospital level of care.
it's like a hospital diversion.
Sure.
Sort of for adults. Okay, yeah. So that being said, these programs, I can see why you're looking at putting it there. Something I'm wondering if you've considered, or if you would consider, is how we are. So we don't hear about it in this committee a lot, but there is like a polysubstance problem out there. It's all over Vermont too. It's not just in Burlington, even though I think we see a heavier percentage than little towns. I hear about it like in Morrisville and these other little towns now. The gangs are coming to Vermont. They're like selling the same drugs everywhere. As this continues, we're going to have an increased need for really serious substance use treatment. And also I read somewhere that alcoholism is like at an all-time high in Vermont. It was in 7 days. So what I'm wondering is like, have we considered, or could we consider, this is like one option, but are there other things missing in the system of care that we need to create that this could also be part of, like secure residential facilities for people who need longer term treatment? Because if there was like a short term piece of that, it could be a doorway into someone staying there if they have a problem. Or if people, I've assessed people in the jail, and it's really horrific when they end up there, because it's usually like they were at the hospital and they were so out of control that they end up in a jail cell. It's like gross in the morning when you go in to talk to someone because of the conditions of someone being sick without medical care in a cell. And then my job is to like get them out of there as quickly as possible and just screen them and be like, they can go home. My point is like, instead of burdening in Chittenden County, I've seen women at the women's facility. I don't know what they do with the men, if they bring them to St. Albans or not. Do they?
I believe so.
Oh, boy. Yeah. So that being said, though, that's a lot of expense of the government. I don't know if the person ever pays that. It's a burden on a night of incarceration is expensive. probably not as expensive as the ER, but what I'm getting at is maybe there's also a piece in the continuum of care for justice involved. People who could, and I know this is going out of this committee's jurisdiction, but you might be able to follow through on this idea of, like, someone gets in trouble regularly for public intoxication, or they commit survival crimes related to substance use. I'm not talking about like violence, but other.
Yeah.
Well, property crime is violent though, when your house is broken into. But what I mean is not murderers. Like,
Right.
obviously that's a different level. That could there be, like, in the continuum of care, some kind of secure residential that people could get like a deferred sentence to that's used instead of the jail? Do you see what I'm getting at? So it has the level of security of a jail, but it's a treatment facility, not like a stainless steel cell with concrete and no medical care.
Yeah. I believe that there were, have been some proposals in a very similar, context to what you're describing. And what I would ask is, to learn more about that, have, the folks at DSU come and provide that info. They did do a gap analysis of the substance use, treatment system over the past year, recognizing that there are some more opportunities to getting folks contact with, services. So this just happens to be the lane that DMH is supporting with. But there's some really great collaboration happening between DSU and the Department of Corrections and such.
That's good to hear. And I want to emphasize, I don't have a problem with this approach, because it's really, if why is a substance use crisis different than a mental health crisis? I know people have special needs, but in my experience, almost always behind the substance use crisis is there's a reason the
Something else
person
happening.
did that. Like, they were depressed, they were acting out, they drank too much. Sometimes people get dosed by someone, things like that happen, but then they're a victim of a crime in a jail. So what I'm getting at is it makes sense I don't know if medicalize is the best word to use. Historically, it's been used oppressively, but to treat substance use as a healthcare matter as much as possible. I think that's what this is trying to do, and I appreciate that. I guess that's what I wanted to say. Even though, like, there might be special needs, like you said, Topper, some people shouldn't be mixed. I get why you're doing this.
Yeah.
So thank you for hearing me out. And
Daisy, did you have a question? And I just want to be respectful of everyone's time that we've already backed up today. And I know that Commissioner Hawes has to leave here by 4.
I'll hurry.
Okay.
I will ask.
Under pressure, I forgot my question.
Was there anything else you wanted to share while you're thinking of your question? Is there anything else you wanted to share from your slide presentation? Because we didn't get through it.
That's okay.
Okay.
I appreciate answering questions in the dialogue. So you can read the slide presentation. Let us know what questions you have, if any. I want to make sure that we that there's sort of an understanding of the repeal, and what that is asking about, and then also our continued efforts to really build a co-occurring response for our communities.
And we were just looking, I just wanted to focus everybody in the committee really quickly. We were just asked to look at the piece around PIP bags, because it coincides with, work we do, hospitals and emergency departments and all of that. So Daisy,
I know what I was gonna ask, and it was around funding. I'm looking at your timeline,
Mhm.
and it appears you all are kind of still looking at funding, financing. And I, first of all, echo Brian, I'm super appreciative and impressed at the partnership in exploring the model. And just kudos to you, especially for leading in this, and just, I'm astounded that you're adding one more thing to your plate and the DA's plates.
It's a big lift, I think, for all of us, but I also think it's what's right.
Yeah.
And that's really hard. Yeah.
Thank you. And I really hope that you find the funding, because I know the budgets coming to us have not
Mhm.
expanded, and yet services required of you all have. I guess that's it. It's just, any thoughts on where you're gonna get the funding to do this?
Yeah. So currently the mental health crisis bed system is a part of our adult case rate. And so what we'll do is pull those dollars out of that case rate and combine those with what's available within the public inebriate system. And it's not necessarily adding beds, but it's a more efficient use to the current beds that we have. So there's not a budget ask in this current year because we want to make sure that we can pull the rate out of the case rate for the crisis beds and make sure that there's that we're using the dollars we have first before there's a potential budget ask. But right now there's not. It's braiding the grant dollars that the public inebriate program has with the case rate dollars.
Would you anticipate needing funding to train more of your staff in co-occurring disorders?
Potentially. There's a lot of great opportunity within our CCBHC work, which is also co-occurring training opportunities. And so there could be some opportunities within that. And TTA or TTI grants through SAMHSA. There are some grant opportunities out there to support training. So
I hope you can hang on to those grants.
me too.
I have exactly 2 minutes because I know Commissioner Oz needs to be somewhere. Did you have a quick question, Woody?
Just going over your people waiting in Vermont emergency rooms.
Oh, sure.
It looks like the youth numbers are dropping,
Mm-hmm.
but and this goes along with what the Vice Chair was saying. Adult persons looks as though those numbers are increasing. Although it's not as great as it used to be.
Right.
And it looks as though those times are 1 to 6 days.
Mhm. I would say 6 is an outlier. We also see around 4 periods of the year where there's an increase in individuals seeking care. And now is one of those times when your days get longer, they get warmer, folks are more apt to seek help. They feel more motivated to get treatment. And so we do see ebbs in the system around this time. We'll see it as with youth as it gets closer to the end of school. We'll see it again with youth as school comes back into session. And then we'll see it again around the holidays where folks are trying to get home, but then also holidays are really difficult for folks. So we see people seeking services more during those times. So we have had folks waiting for 5 or 6 days, and that's usually due to a complicated medical issue that can't be adequately served on an inpatient psych unit. And so we're typically waiting for a bed within a medical facility that can serve an individual.
Thank you. Thank you for coming in.
Yes, thank
Sorry
you.
for the technology issues. You didn't have, but you did a great job without.
I read the whole thing too.
Yes.